Coming to hyperemia, hyperemia, it is a regulatory response. Usually clinically we see it manifests as erythema, and it is usually because of the fall in the atmospheric pressure compared to the outside body. And functionally, it can be classified into two types. First one is a functional metabolic, otherwise known as active hyperemia. In this condition, we see that the active cells, when there is any decrease in the oxygen or otherwise fluid, such as known as glucose or fatty acids, this might also cause, when there is increase in this active cells with oxygen and fluid, there might also, because of this increase in the oxygen and fluid or fuel substances, there will be increase in the metabolic processes. Because of this increase in the metabolic process, obviously the reactions or metabolic reactions might result in increase in the byproducts, and these byproducts they constitute the carbon dioxide, protons, as well as the potassium ions, as well as adenosine, and these byproducts, they act as vasodilators. Since the function of the vasodilators is to enlarge the vasculature as well as increase in the amount of the blood flowing within the vasculature, this might result also in local dilation of the arterioles. Though there will be local arterioles also undergo this condition of dilation, and because of this there will be increase in the blood through the tissue, and this condition is known as active hyperemia. Coming to the reactive or otherwise known as venous hyperemia, in this condition we see when there is conditions such as ischemia, that is when there is decreased in the or inadequate circulatory blood fluid. Because of this decreased blood flow, since as blood also has a function of carrying the oxygen, there will be also decrease in the amount of oxygen being carried to the organs. Because of this, since oxygen is involved in also debriding the metabolic waste, that is removing the metabolic waste from our body, and since because of this reduced oxygen supply, there is decreased metabolic waste being removed from our body, because of which there will be increase in the building up of the or accumulation of this metabolic waste. Because of this accumulation of the metabolic waste, there will be ultimately increase in the organ blood flow, transient increase in the organ blood flow. So this is known as reactive or otherwise known as venous hyperemia. Coming to the passive hyperemia, which is also known as venous congestion, it can be defined as dilatation of the veins and as well as capillaries because of the impaired venous drainage, which is because of passive hyperemia or otherwise venous congestion, which is commonly referred to as congestion. And usually this congestion could be of acute type or chronic type based on the duration as well as based on the rapidity of the effect of the hyperemia. And usually clinically we see that the patient might undergo cyanosis because of the increased venous pooling of the blood or increased venous blood. It might result in a condition known as bluing of the skin, which is known as cyanosis. And other than that, it can also be classified as local venous congestion, that is when it is affected with accumulate only to a particular organ, or otherwise when it is generalized, that is within the entire body, it is known as systemic or generalized venous congestion. Coming to the particular organs which are being affected by this congestion, it is known as this chronic venous congestion of the liver can be characterized when it affects the liver. It is mostly seen in left heart failure, and usually macroscopically, that is a gross specimen, it usually seen as heavy. The lung appears heavy as well as firm in consistency. And we see microscopically, we see that there is hemorrhagic areas within the alveoli, and this condition is known as intra-alveolar hemorrhage. Other than that, we also see certain heart failure cells. Heart failure cells are nothing but the hemorrhagic area which are being present over the fibrous tissue. These hemorrhagic area which constitutes the red blood cells, when they release the hemoglobin pigment, and this hemoglobin pigment when it is being released is known as hemosiderin, and when this hemosiderin is being taken up by the alveolar macrophages, that is the macrophages which are present within the lung, then these appear as brown to reddish in color, and these cells, alveolar macrophages which have taken up the hemosiderin or the blood pigment which is being released by the red blood cells, is known as heart failure cells. So they are being constituted within the particular organ in lung when it is being affected with CVC. Coming to the CVC of liver, usually we see in conditions when there is right heart failure, otherwise when there is any blockage to the hepatic vein, or otherwise when there is a hypertension of the hepatic vein or hepatic system, this might result in CVC of lung. Usually we see the liver, it is usually enlarged, the gross specimen appears enlarged, and it might also show hemorrhagic areas. And coming to the microscopic feature, usually the most commonly it is a centrilobular zone within the liver which is being affected when compared to the peripheral region. And within the centrilobular region, we see that there are numerous hemorrhagic areas which are being replaced by necrosis and finally via fibrous tissue. And other than that, we see even fatty changes can also be seen within the CVC of liver. Coming to the CVC of spleen, usually we see in conditions when there is right heart failure, which is a consequences for the CVC of spleen to occur. Macroscopically, that is a gross specimen, it might be seen moderately to severely enlarged spleen. Splenomegaly can be seen of the particular patient, and microscopically we see that the sinusoids are being replaced by this hemorrhagic areas, which is known as capillarization of the sinusoid. And other than that, we also see gamma Gandhi bodies, which are nothing but the sinusoidal areas being replaced by this nutmeg kind of appearance and hemorrhagic area, and this is known as gamma Gandhi bodies. So gamma Gandhi bodies, they are usually the hemorrhagic areas which are seen upon the fibrous tissue, and this fibrous tissue, hemorrhagic areas on this fibrous tissue along with the hemosiderin pigment, this condition is known as gamma. These particular typical features are known as gamma Gandhi bodies, and it is a characteristic feature as chronic venous condition of spleen. So this is what we see in CVC of spleen. Coming to CVC of kidney, grossly we see that the kidney is enlarged as well as there is congestion of the medulla. Along with that, microscopically we see there is numerous degenerative changes within the tubules as well as within the glomeruli of the kidney. Along with that, as the condition progresses, we see there is cloudy swelling and fatty changes undergoing within the kidney. And most commonly we see the proliferation of the mesangial cells. This is also one of the characteristic features of CVC of kidney. Usually this condition of CVC of kidney is once the consequent changes when there is any block within the renal arterial system. So this is what is a CVC of kidney. Coming to the hydropic change, it is defined as the accumulation of water within the cytoplasm of the cell, and can also be caused as cloudy swelling, which is a synonym of hydropic change. And usually we find that there is vacuolar degeneration because of the accumulation of water within the cell. The cell completely is being occupied with this water, and upon processing and upon appearance of under a microscope, it gives appearance of the degeneration of the complete vacuole, clear vacuole, because of which it is being termed as vacuolar, also known as vacuolar degeneration. It is usually a reversible change. Once the injurious agent is being removed, it can revert back to its normal position. The etiological agents usually include the bacterial toxins, chemicals, or otherwise any kind of poisons or intravenous administrations. And conditions such as burns and high fever can lead to this kind of cloudy swelling. Coming to the pathogenesis, it is usually because of the impaired sodium and potassium efflux as well as influx, and because of which there is increased intracellular accumulation of the sodium, and there is prevention of the potassium, that is to the outside, prevention of efflux of potassium, as well as and there is more of calcium influx, because of which there will be rapid flow of water into the cell and results in a condition known as isoosmotic condition, and this condition in turn leads to swelling of the particular cell. And grossly it depends on the affected organ. It shows usually enlargement, and microscopically we can appreciate presence of clear vacuoles in the swollen cells, and other than that we also find extracellular formation of the cytoplasmic cell organelle, and this is known as cytoplasmic blebs. And because of the increased accumulation of increased pressure being performed pushed up by the water or the fluid whichever is being accumulated within the cell, this might compress the vasculature, and because of which the vasculature within the cell, that is a microvasculature, it appears compressed. And other than that, we find a pale nucleus. It is probably because of the increased fluid content which makes the nucleus uptake the hematoxylin stain, take up and dilute it, and result in appearance of pale nucleus. Coming to the mucoid change, usually it is seen associated with the mucus secreting mucus glands, and this constituent within the mucus glands, it contains proteins as well as mucopolysaccharides. This mucoid changes can be occur in either in epithelial mucin associated with epithelial mucin, or otherwise connective tissue mucin. They can be classified into epithelial as well as connective tissue mucin based on specific stains, where epithelial mucin stains positive for the pyridic acid skip stain, whereas connective tissue stain, it stains positive for colloidal iodine. And this epithelial mucin can be derived from the catarrhal inflammation of the mucous membranes in cases associated with the nasal mucous membrane, or otherwise ocular mucous membranes, or otherwise even in case of ductal obstructions associated with the salivary glands, or cystic fibrosis, or otherwise mucus secreting tumors. Coming to the connective tissue stains, we see these stains, mucin, that can be derived from the mucoid degeneration, otherwise dissecting aneurysm, or otherwise in case of myxomatous changes or myxoid changes. So these are the derived etiological agents for this particular epithelial as well as connective tissue mucin derivatives. Coming to the adaptive responses, usually a normal cell, it is usually confined to its state and function based on its condition, that is its states, as well as its relationship to the adjacent neighboring cells, as well as based on the metabolic activity functions. When there's any injury to a normal cell, it might either show atrophy, that is it might change in the size and shape of the cell, or otherwise it might increase in the number of the cell, known as hyperplasia, or otherwise increase in the size of the tissue, known as hypertrophy, or otherwise change in the form of the cell, known as metaplasia, or otherwise disordered change in the cellular arrangement, known as dysplasia. So these are the certain adaptive responses which our body tries to compensate with that of the exposed injurious agent. Coming to atrophy, usually it can be defined as the reduction in the number as well as size of the parenchymal cells of an organ, or otherwise its part which was once normal. And usually the organ appears to be shrunken because of the decreased size and number. And other than that, we also see there's increase in the number of autophagic vacuoles, which are usually confined to a process known as autophagy, where it tries to remove the abnormal cells from the body. And this atrophy can be classified into physiologic atrophy or otherwise pathologic atrophy. Physiologic atrophy in case of atrophy of lymphoid tissue, that is in case of lymph nodes, in case of thymus can be seen, whereas in case of atrophy of gonads after condition of menopause can be seen. Atrophy of brain can be seen in case of aging individual. Coming to the pathological atrophy, we see in case of starvation, where the cell carbohydrates as well as proteins are being utilized. And case of ischemic atrophy, we see when there is decrease in the blood supply. And disuse atrophy is a condition where we see usually when there is any particular limb being immobilized within a cast. This results in diminished activity, physical activity, and result in disuse atrophy. Coming to neuropathic atrophy, it is seen in conditions of cerebral encephalopathies can be seen. And in case of endocrine atrophy can be seen in conditions of hypopituitarism as well as hypothyroidism. Pressure atrophy, when there's in case of tumors and cyst formation, might result in pressure atrophy. Idiopathic atrophy, because of any unknown cause, it might result in unetiological idiopathic atrophy. So this is what is about atrophy. Coming to hypertrophy, it is usually known as increase in the size of the parenchymal cells, resulting in enlargement of the organ or otherwise tissue without any change in the number of the cells. And the affected organ, since the increased size, it results in enlarged as well as heavy affected organ. And it can be classified into physiological or otherwise pathological atrophy. Usually we see most commonly given example of physiological hypertrophy, it is the enlarged size of the uterus in case of pregnancy, or otherwise in case of maturation can also be seen. Coming to the pathological hypertrophy, we see in case of hypertrophy of the cardiac muscle can also be one of the illustration, as well as hypertrophy of the smooth muscle. Hypertrophy of the skeletal muscle can also be given, as well as compensated hypertrophy can be given as few illustrations for the pathological hypertrophy. So there is a picture which shows that the presence of first line of cells, which shows normally present cells with normal nucleus, whereas in case of hypertrophy, we see there is an increase in the size of the cell and abnormally placed nucleus can also be seen. And in case of hyperplasia, we see there is increase in the number of the cells. Coming to hyperplasia, we see that here hyperplasia is a condition where we see that there's increase in the number of the parenchymal cells, resulting in increased enlargement of the organ or otherwise in the tissue. Because of this increased number of cells, it might ultimately result in increased enlargement of the affected organ as well as tissue, as well as increase in the number of the cells. Usually we see in physiological hyperplasia can be an illustration of hormonal hyperplasia can be given in females in conditions of pregnancy period, and lactation period can also be given an example of hormonal hyperplasia. And compensatory hyperplasia can also be given when there's any damage or any injury to a particular, or otherwise when there's any blunt cut to a tissue. It might show epithelial hyperplasia, that is where the epithelium tries to cope up with the loss of the cells, and this is known as compensatory hyperplasia. Coming to the pathological hyperplasia, we see endometrial hyperplasia in case of pregnancy, as well as in wound healing we see. Similarly, we see formation of granulation tissue, as well as fibrous tissue hyperplasia, as well as epithelial hyperplasia, which tries to cope up with that of the wound healing and result in ultimately a pathological type of hyperplasia. And also we see in conditions of pathologic hyperplasia of the epidermis, in conditions of ulcers formed within the epithelium can also be seen. Conditions of rodent ulcer can be given as an illustration. And other than that, we also see in pseudocarcinomatous hyperplasia can also be given an illustration of the pathologic hyperplasia. Coming to the metaplasia, usually it can be defined as, metaplasia can be defined as reversible change of one type of epithelial or mesenchymal adult cells to another type of adult epithelial or otherwise mesenchymal cells. Usually it is in response to an abnormal stimuli, otherwise it often reverts back to normal when the stimulus or injurious agent which has initiated its cause has been removed. So this metaplasia can be classified into epithelial metaplasia as well as mesenchymal metaplasia. Epithelial metaplasia can further be classified into squamous metaplasia, that is where the cells try to change from squamous to another form of cells. Whereas in columnar metaplasia, we also see in conditions of allergies where that the squamous metaplasia within the nasal mucous membrane might try to undergo changes as an adaptive response. It might turn to columnar metaplasia in case of allergies in nasal mucous membrane. Similarly, mesenchymal metaplasia can be seen in conditions such as tumors. We see that or otherwise in case of bone tumors, we see that the chondrite tissue, it might further undergo into an osseous tissue known as osseous metaplasia. Similarly, cartilaginous metaplasia, because of the abnormal deposition of the bone in conditions of osteoma or osteoblastoma, we see that there is deposition of bone upon this cartilaginous tissue and might result in cartilaginous metaplasia. So these can be given a few illustrations of metaplastic changes. Coming to dysplasia, it is usually a disordered cellular development which is being often accompanied by metaplasia, that is change in one form to another form of cell, or otherwise even it can also be associated with hyperplasia, that is increase in the number of cells. It can also be termed as atypical hyperplasia, since the number of the cells have been increased, but rather this change in the form of the completely the cells do not resemble that of the parent cell. So they are known as atypical hyperplasia. So usually we find the dysplastic changes, they include the increase in the number of the epithelial cell layers and the arrangement, there's no proper arrangement of the cell layers, which is nothing but disorderly arranged cell layers, and there's loss of the basal polarity. Normally in the basal epithelial cell membrane, we see the nucleus is towards the basal cell membrane, but in dysplastic change we see the nucleus being pushed away from the basement membrane. This is known as loss of basal polarity. And next, other than that, we also see various morphological changes in the cell form as well as nuclear form, and this is known as cellular and nuclear pleomorphism, which is also one of the dysplastic change. The other form of dysplastic change, it is known as increased nuclear cytoplasmic ratio. Usually the nuclear cytoplasmic ratio is in a 1:4 ratio, but in a dysplastic change we see that the nuclear cytoplasmic ratio it might range from 1:4 to 1:2. That is, the nucleus and the cytoplasm, they come to an equal ratio. And then other than that, we also see the darkly stained nucleus, which is known as nuclear hyperchromatism, can also be seen as one of the dysplastic changes. And since dysplastic changes we see increase in the number of cells, nothing but hyperplasia can also be seen. So there is increased even in the mitotic activity, nothing but increasingly dividing number of cells can also be seen. So the picture here, it shows it is a cytological preparation, exfoliative cytology, where it shows that there is dysplastic cells with variation in the size and form of the cell as well as that of the nucleus. So this is what is about dysplasia. Coming to the differences between metaplasia and dysplasia. So by definition, metaplasia can be defined as change in one type of a epithelial or mesenchymal cell to another type of adult epithelial or mesenchymal cell. Whereas dysplasia is defined as disordered cellular development which may be accompanied with hyperplasia or metaplasia. Coming to the types of metaplasia, it is the epithelial metaplasia as well as mesenchymal metaplasia. Coming to the types of dysplasia, it is only epithelial type of dysplasia. We do not see dysplastic features confined to the connective tissue, but it is only confined to the epithelial cells. Coming to the tissues affected in metaplasia, it is most commonly seen affected with bronchial mucosa as well as uterine or endocervix, or otherwise even other mesenchymal tissues such as cartilage, even arteries. Whereas in dysplasia, we see it is mostly confined to the uterine cervix as well as to the bronchial mucosa. Coming to the cellular changes in metaplasia, we see that there is mature cellular development in metaplasia. Whereas in dysplasia, we see that there is disordered cellular development, which is termed as pleomorphism, nuclear hypochromatism, altered nuclear cytoplasmic ratio. Coming to the natural history in case of metaplasia, it is mostly we say that once a stimulus or injurious agent is being removed, these revert back to normal. That is, it is a reversible in case of withdrawal of the stimulus in case of metaplasia. Whereas in case of dysplasia, we see that the condition might regress, or otherwise on removal of the inciting stimulus, it may, or otherwise it might progress to a higher grade of dysplasia, or it might also turn up into carcinoma in situ. So these are the natural history based on the metaplasic as well as dysplastic changes.